Well, thank you very much. It's a pleasure to be here in sunny Arizona where there's no snow on the ground. And my compliments to the conference organizers. I'm going to speak about ATLS and the foundations for the 8th and ninth edition revisions, but the quality of the speakers so far today has been outstanding, and I think you've heard some of the things that will influence the 10th edition. So I've learned a lot today, and I've really enjoyed it. So thank you very much. I'm going to speak to you about ATLS. I served as the chair for the 8th edition revisions, and it was a great privilege and honor. I first took ATLS back in the mid-'80s, and it really was transformative. I was a young resident. I walked into this new course that was probably one of the first competency-based training examples in surgery, and emerged 3 days later feeling much more confident in my abilities to manage trauma. So it really was something that changed medicine and surgery for me. I've been teaching ATLS ever since, and as many of you do, I participate in a lot of different courses and educational formats, but I still really enjoy being part of the ATLS program. It's just a pleasure, and the course just keeps getting better and better. And it also is becoming more prevalent and important in the world, and I'll talk about that in a minute. So I'm going to go through a few things in the next 20-25 minutes, background and organization of the course. We'll talk about the editorial process and the content revisions. I'm going to go through some of the revisions, not all of them, but I'll just highlight some of them. And in a few cases, I'll highlight some of the evidence that supported those changes. A little bit on the educational format, and I'll just tell you what the future looks like for the course. So the course itself is a product of the American College of Surgeons. And the American College of Surgeons was founded by a group of academic surgeons from the United States and Canada in 1913. And they founded the college because at that time, surgical care was very heterogeneous. It wasn't standardized. It was of poor quality in many cases. People would advertise services with little or no training, no standardization, no quality control, et cetera. So they created this organization to improve hospital surgical care. For the same reason, a group of surgeons recognized that the care of fractures within hospitals was woefully inadequate, and they founded the Committee on Trauma, which soon thereafter, after World War II, became the Committee on Trauma, which we're familiar with today. The ATLS program was adopted by the American College of Surgeons in 1978 and rapidly adopted across the United States and Canada, so that it became one of our standards of training for surgery, emergency medicine, and anybody involved in trauma resuscitation by 1980. James Steiner was the orthopedic surgeon whose plane crash in Nebraska resulted in the personal experience that led him to create the course. Those of you who are familiar with the story will remember it. His wife died and his 2 children were severely injured, and he was awake but severely injured, so he was able to understand what was happening to him and his children during his care. He didn't like what he saw, and he decided to do something about it. Standing beside him is Jamil Ali, who's probably the longest-serving member of the ATLS subcommittee and is a surgeon educator from Toronto. And he and many people like him have worked with Steiner and colleagues to create the ATLS course and make it what it is today. One of the important people, and perhaps the person who's most responsible for ATLS surviving and flourishing, is Irvine Hughes, who was actually a CCU nurse in Nebraska, who joined the team to create the course. And she, with her nursing background, ensured that there was standardization and adherence to policy. And that resulted in a high-quality course that remained standardized across many, many different cities and now countries. And I think without her at the helm, that wouldn't have happened, because physicians are notorious for being diverse and individualistic, so she also gets a lot of the credit. The course now has spread throughout the world. It's in approximately 60 countries. The last 3 countries to promulgate in the past year were Georgia in the old Soviet Union, the Philippines, and it's going to Mongolia this spring, which is a unique challenge because none of the physicians there speak English. So we're having to do all the promulgation training and initial coursework in Mongolian translation, but it just shows you how far the course has spread and gone. That has created some challenges for the editorial process and the content revisions. When you involve people from around the world, getting consensus, as you can imagine, can be somewhat difficult. And one of the rules that we've had to institute in order to get consensus is that the changes going forward will be evidence-based. We adopted Wright's evidentiary table, which is a very simple and easy to use evidence-based table. It divides in medicine into treatment, prognosis, diagnosis, and decision analysis, and grades it from 1 to 5, and those grades are almost intuitive. If we have level 1 evidence, that is pretty easy, and that will result in content changes. If the change is only supported by level 4 or 5 evidence, then we need almost universal consensus to make the change. So that's how we've managed to get the different corners of the world to agree on common course content going forward. At the end of the day, you still have to have a group of people that come together and review that evidence, review the suggestions for change, and make sure there is adequate consensus, particularly on the lower level recommendations. And this is an example of one of those working groups. There are actually 4 of these small group sessions going on at the same time with surgeons and ICU docs, emergency physicians, and nurses who participate from around the world. And we will have these meetings 2 to 4 times, particularly in the 1 to 2 years leading up to the new editions. So the 8th edition changes were published in the Journal of Trauma in 2008, and they were, this was quite an extensive transformation. There were over 30 content changes and over 200 references categorized by levels of evidence. I think it's important to understand what the ATLS course is all about. So what ATLS does is it improves knowledge which can be translated into action, particularly by young or inexperienced individuals. We know that trauma systems make a difference. ATLS or any standardized course is part of a trauma system. Trauma education and sustaining a workforce is part of what makes a trauma system effective. So ATLS by itself isn't the agent of change, but it's one of the important tools that is used by trauma systems. Currently, the chair is Karen Brazel. She's a trauma surgeon from Milwaukee, and she's done an outstanding job of overseeing the 9th edition, which was just released. The goal of ATLS is to provide a common language that can be used wherever it's taught. And certainly in North America, that was readily apparent in the 1980s. We were all speaking the same language. And now that language has been adopted across most of the world. The other thing that's important about ATLS is it's not the only way to manage trauma. It's one safe way. So it doesn't prohibit people or institutions or centers from doing it differently. It just offers one safe way and one package to manage trauma. So let's get on to the meat and talk about some of the revisions that have occurred in the 8th and 9th edition. First of all, in order to support the learning principles and the science of learning, there is one mission statement or objective that's clearly identified at the beginning of each chapter. The other thing that's important is not only is ATLS, it currently is and always has been a competency-based medical education format where you identify the change you want to instill in the learner and then measure it. But it also is moving to problem-based learning, so each chapter now has one case with a conclusion that runs through each chapter to make it more relevant. Some of the changes include teamwork. That's important. ATLS, I'm sure all of you have heard this, and I've heard it at many conferences. People will say, well, it's nice, but really it's for the one doc in the small town with one nurse helping them. And I personally have never found or felt that to be true. I work in, and always have worked in, large trauma centers, and the ATLS principles have always been relevant to me as a trauma team leader, whether they're performed sequentially or at the same time. But the book is clear and states it clearly now that the principles of ATLS are intended for all, whether you're doing it in a team environment or in a solo practice environment. What ATLS is not is a team training course, and that's been discussed, but it's felt that the resources and time required for a really good team training course are beyond the 2.5 day schedule of ATLS. So a number of team training courses are emerging, and most of them identify ATLS as foundational work that has to be completed by docs participating in the team, and likewise for nurses, TNCC or ATCN, and for pre-hospital providers, PHTLS. We all need to speak the language before we start working together as a team. Reevaluation is emphasized in the new course. Again, ABCs are important, but patients are not static, they're dynamic, things change, and you need to be able to carefully reevaluate and reassess. The problem of obesity, which is increasing across the Western world, is now highlighted, and some of the unique challenges that poses. The C-spine X-ray, which used to be part of the primary survey, has been moved off to the secondary, both because it's not an immediate life-threatening assessment and also because imaging for excluding spine injuries evolving. Airway was the source of many of the changes both in the 8th and 9th edition. So typical presentation, blunt trauma, gentleman requires intubation for blunt chest trauma. How would you manage this patient? So some of the significant changes that were introduced were some of the new adjuncts for airway control, the LMA and the King airway, which you're familiar with. The gum elastic bougie, very simple, cheap device that was first popularized in Europe, but can be very useful for difficult airways. Introducing the concepts of how do you know you're in the right place, look, listen, feel, oximetry, and capnometry or capnography, an updated algorithm, and more recently fiber optic laryngoscopy, which has revolutionized airway capture. The airway algorithm that was introduced was based on very complex but thorough and updated algorithms developed by societies in critical care, in anesthesia, and emergency medicine. And ATLS simply took the concepts and applied the KISS principle to translate it into something that our learners could understand. And as you walk through it, really it says, you know, can you oxygenate the patient for a few minutes, and do you have time to think about it? And if so, is the airway easy or hard? It provides examples of looking for what might be a difficult airway using different assessment tools like the Lemon technique, for example. You know, look, evaluate Mallampati obstruction, and is the neck mobile? And those are just to make the student think about what a difficult airway might look like. If it's easy, go ahead with drug-assisted or RSI, whatever your institution uses. If it's difficult, the first thing you need to do is get help, and then start applying your adjuncts and your difficult airway algorithms. Some of the literature that supported these airway changes, I just want to run through a few good examples. This was a study out of Ann Arbor that looked at emergency intubation. These are the ones that we typically see outside of the operating room, and what was the experience with them like. And they identified that roughly 10% were difficult, that there were complications in about 4% of those difficult intubations. They used the bougie about 12% of the time to capture the airway, and they found that predictors of complications were 3 or more attempts and grade 3 or 4 view, not too surprising. This is an interesting paper that looked at the more recent use of the fiber optic laryngoscope, and this was an interesting study in that they took medical students, gave them structured training on mannequins, and then they allowed them to randomly they assigned them to intubate patients. They had informed consent from patients who were presenting for surgery, and the students were either given a Macintosh or a fiber optic laryngoscope. So this is about as green as you can get, and you can see that they were successful a third of the time with the Mac and 83% of the time with the rigid fiber optic laryngoscope. So pretty good evidence that for inexperienced personnel, the fiber optic laryngoscope makes a huge difference. Another interesting study where they looked at patients who had their spine immobilized in a C-collar, and again, these were patients who were presenting for surgery who gave consent, and a collar was applied to them before induction, and then they were assessed using a Macintosh and a fiber optic laryngoscope, and found to have a much easier visualization with a fiber optic scope and rapid intubation times despite being in the C-collar. And then finally, this is an analysis of using the fiber optic laryngoscope in thousands of patients that required GlideScope intubations. This is in 2 academic medical centers. Huge number of intubations, both intra-op and out of the operating room. But of the 70,000 intubations, 2,000 were performed for different reasons using the fiber optic scope. And they found primary success almost 100% of the time. And if they were using it as a salvage technique, the success rates were still in the high 90s. So I think that technology has really revolutionized airway control, and the technology just keeps getting better. Pediatric airway, the big change was uncuffed tubes. So historically and in all the textbooks, the advice has been don't use cuffed tubes in neonates and infants. And that changed recently. There have been a number of publications saying it's safe to use cuffed tubes in small children. ATLS still has not adopted it for less than 1 year of age because most of the studies have excluded that group. There's one exception, which is this paper, which was a European paper that looked at the application of new technology using cuff tubes in children from birth to age 5, and found that it was very safe in all of those children. Part of the reason it's safe is that these new pediatric tubes have a blow-off valve, so you can't overinflate the cuff, and they also are specifically sized so that the inner and outer diameters of the tube are close, and you're not going to inadvertently put in an oversized tube and damage the trachea and the larynx. So I think we're going to see further evolution in the recommendations going forward, but uncuffed tubes for children are here to stay. How about patients in shock? So a 30-year-old male presents with a fall of blood pressure, systolic of 60. He's got a positive FAST. Chest X-ray and pelvic X-ray are normal. How would you resuscitate this patient? Should you always give 2 liters of crystalloid? So the 8th edition introduced the concepts of balanced resuscitation and identified that you have to be cautious, and that patients with traumatic brain injury, maintenance of normotension and avoidance of hypotension are still critical for the outcome of that patient, whereas in penetrating trauma with shock, the emphasis needs to be on stopping the bleeding, not on resuscitating to normal blood pressure. The 9th edition started incorporating the concepts of massive transfusion that we've heard about a little bit today, and we'll hear more about tomorrow, emphasizing that massive transfusion protocols, which have made a huge difference in reducing the chaos of resuscitation, need to be part of the approach to these patients. This is the text that's in the book, and I think it's important to read, so I'm going to read it to you. Balancing the goal of organ perfusion with the risks of rebleeding by accepting a lower than normal blood pressure has been termed controlled resuscitation, balanced resuscitation, hypotensive or permissive resuscitation. The goal is the balance, not the hypotension. Resuscitation strategy is a bridge to, but is not a substitute for definitive surgical control of bleeding. So that's the concept, and the idea is you have to apply some clinical judgment and do the right thing, and for patients who are bleeding to death with penetrating trauma, the right thing is to get them to the operating room and stop the bleeding. For patients with blunt trauma, where there may be multiple sources of bleeding with a head injury, you need to maintain cerebral perfusion while you're sorting out where to go next to stop the bleeding. We've also heard and listened to the comments regarding aggressive resuscitation with crystalloid, and the book does not say give 2 liters of crystalloid. It says use your judgment. You can start with crystalloid, but be cautious. The important thing is early adoption of massive transfusion protocols when appropriate. The book identifies that there's still clinical equipoise between Ringer's saline and hypertonic saline. I'll speak a little bit more about that tomorrow with the top 10 papers review. Angioembolization, as we all know, has become prevalent for hemorrhage control. Thoracotomy is replacing pericardiocentesis for penetrating trauma as the initial maneuver and intervention. And the concepts of measuring and monitoring shock through base deficit and lactate are both part of the course. There's some excellent publications on massive transfusion and shock. The references and the updates on the 8th and 9th are extensive. I'll just mention a couple. This is one by Hess and Brohe that is a beautiful read if you want to understand the pathophysiology of coagulopathy associated with trauma. I learned a lot from reading this paper. You should all put it on your reading list. The other one that is worth looking at is, this is an editorial by Mayer on the PROMIT study that I'm going to talk about tomorrow, which is a massive transfusion paper. But Mayer also presented the Scudder Oration on Trauma at this year's American College of Surgeons meeting in Washington. It was a beautiful discussion on the history and the current standard of practice for coagulopathy and trauma. It should be in print soon, and again, put it on your reading list. It was a great lecture, and it'll be a great paper. This is a pedestrian struck by a truck, presents in shock. How would you manage this patient? So we know that pelvic trauma and abdominal trauma are both part of the constellation that can produce shock and blunt trauma, and they need to be managed concurrently, and so the book tries to capture that. The book is not prescriptive about intra versus extraperitoneal packing. It simply says if there's a problem, they're bleeding, could be belly, could be pelvis, get surgeons involved, wrap the pelvis, especially for open book, decide where you're going next, angio or laparotomy. If you've got a pack, decide if you need to do so. So it sort of bundles things together, and pelvis and abdomen are now combined in one chapter. couple of papers that look at this and that have demonstrated the benefits of having a combined multi-professional team-based approach to pelvic fractures and hemorrhage. This is a European study out of Innsbruck, and they looked at a large number of pelvic fractures, 45 of whom were in shock requiring transfusion. They applied multimodal team standardized therapy, and their patients no longer bled to death. Many of these patients still went on to die from severe sepsis or head injury. It's a badly injured high-risk population, but historically, many of these patients would have bled to death. So pretty good evidence that this team-based approach works. Similar experience in North America out of Denver, where they had a team-based approach with pelvic wrap, fixation, pelvic packing. They often used the extraperitoneal approach if they didn't need a laparotomy. And again, their patients did not bleed to death. And compared to historic comparators, their survival rate was increased. So I think we've learned a lot about managing complex pelvic injuries, and we're a lot better than we used to be. The FAST is again part of our standard assessment in trauma, and the ATLS course recognizes that. It doesn't teach how to do FAST, that's beyond the time limit of the course, but it does tell the students to think about how FAST results should be applied. When do you do it? Who do you do it on? And what does the information tell you? How is it useful? Tourniquets were reintroduced in the 8th edition, primarily based on experience in the military. The published data are simply case reports or case series, but it was clear from the military experience that even with level 4 evidence, it was preventing people from bleeding to death, and there was consensus around reintroducing it into standard civilian trauma care as well when used appropriately. What about shock? This is a 25-year-old male who presents with a stab wound below the xiphisternum. His blood pressure is 90. Before you operate, would you do a DPL? Would you perform a pericardiocentesis? Or would you perform a FAST? So when I trained, the right answer would have been DPL and pericardiocentesis, and then maybe a subxiphoid window, unless he crashed, in which case you do a thoracotomy. So things have evolved quite a bit since then. This patient almost certainly would get a FAST exam in the emergency department now, but if he was in shock and you thought he had a tamponade, you may not rely on your FAST and proceed anyway. Pericardiocentesis no longer is a diagnostic tool. It's evolved from diagnosis to therapy, and now I think its therapy is being supplanted by surgery in most trauma centers. So FAST is emphasized as the diagnostic tool for both supplanting pericardiocentesis and DPL. DPL is still taught because some places in the world where we teach ATLS don't have access to FAST. That's why it's in the course, but it's now optional. You don't have to teach it. Pericardiocentesis is still in the course for a different reason, and I'll talk about that. So pericardiocentesis was one of those things where the majority of the members of the committee and the people providing support or for the ATLS enterprise thought it should be eliminated, but a small cadre felt it was still necessary. So we agreed that we would make it optional and we would publish our own systematic review, which we did. It just came out in Journal of Trauma this month. And it's interesting. It's based on case series and case reports, but it still tells a story. And you can see that when pericardiocentesis was first popularized back in the 70s, it was widely used. And it was widely used both with thoracotomy, but as both a diagnostic and therapeutic tool. So many people would write that they did pericardiocentesis, retrieved clot or blood, and saved the life of the patient, and nothing more needed to be done. That raises the question on diagnostic accuracy, but you can see over time that there were fewer and fewer reports of pericardiocentesis in subsequent decades, and certainly almost no cases of it being used alone. If you look at thoracotomy on the other side, you can see that its use for penetrating cardiac trauma has gone up, and its use in isolation has gone up. One of the meetings I attended last year in Brazil, one of the Latin Americans put up a big slide that had pericardiocentesis with a giant red X through it. So in centers that do a lot of surgery for penetrating cardiac injury, ATLS was losing credibility because of its continued teaching of pericardiocentesis. So based on this review, what the paper says is that if you work in a trauma system where your providers are likely to see penetrating trauma to the heart, and they're likely to work in a center that doesn't have surgeons, and they're likely to be able to get that patient to a surgical center in a short period of time where they can still survive, then you might want to consider teaching pericardiocentesis. If you don't meet those criteria, it's probably not worthwhile. Final couple of changes in content. This is a male who presents with a GCS of 8 seizures and a temperature of 41. What would you do? Well, why are we talking about this in the ATLS course? This is why. If you look at the world, ATLS started with a chapter on cold injury, which included not just hypothermia, but trench foot, frostbite, chilblain, etc. Now, I understand those things working in Canada, but a lot of places I've been to run ATLS courses, when you give the heat and cold, the burn and the cold injury talk, they start laughing. Because in Saudi Arabia, they don't see frostbite. In Arizona, you could probably go both ways. So the heat injury talk was introduced as a complement to the cold injury talk, and countries or regions were given the choice of which one they thought was most relevant to their center. So quickly, some of the changes, you approach it with the ABCs. The risks obviously are DIC, rhabdomyolysis, and multi-organ failure, and a rapid reduction of body temperature is associated with improved survival. How can you treat it? Well, ice packs, wet gauze fan, that would be the easy way. Immersion if you have it. It's more complex and difficult to manage the patient. Or a body cooling unit. There actually are a couple of studies. The literature on this is pretty limited, so if any of you are looking for an opportunity to publish, here's a study you could probably do in Arizona. This was an observational study out of Connecticut looking at runners, and they did water immersion versus air exposure in cold towels, and the immersion group did better, got better faster, and had improved results. These are the body cooling units, which are used for some large sporting events. They use these in the Hajj in Saudi Arabia for the pilgrimage to Mecca, because they have millions of people who present, and hyperthermia and heat stroke are actually quite common, so they're quite effective there. A few words on educational format. The multiple choice questions were revised for the 9th edition. For the first time, psychometric testing was applied, and tools that looked at each individual test item were reviewed, and we looked at the test items to look at two things. One, did students, was the pass rate around 80% on individual test items? And secondly, if students did well on a test item, did they also do well on the whole test? That's called a PBRI, and it means that the test item is good if there's a correlation. So all of the questions were rewritten and subjected to this analysis, and they were beta tested on instructors, and the results looked pretty good. Then we rolled them out for the 9th edition, and the psychometrics were indeed much better, but not surprisingly perhaps, the pass rate went down because the test items were harder. So as a result of that, the pass rate for the course is going to be adjusted to maintain about the same ratio of students who pass or fail going forward. The other change in educational format is to the instructor course, which really is going to apply even more feedback than we did historically in going from the Pendleton to the Pendleton Plus, so the sandwich technique that you're all familiar with, good, bad, good, and just providing more feedback with specific examples and role modeling. E-learning, this probably will transform the course once again. The e-learning idea is that students will be able to take all of the didactic portions of the course online and simply have to present for an abbreviated course that covers the practical skills. I suspect that'll become a preferred model in North America because of some of the time challenges for faculty. But every region or course will be able to choose which format it wants, and the e-course should roll out hopefully within the next year. The beta testing is about to begin soon. The other thing that was significant on the 9th edition was the addition of an app. Those of you who've taken the 9th edition of the course have a free download for the app. The app has a lot of different features, and I love to use it as a teaching tool now in the wards because of all the videos of different procedural skills that I can demonstrate to my students and residents. It also has some nifty calculators, Parkland formula. You can just punch in the weight and the body surface area burn, and whammo gives you the fluid resuscitation guidelines. So lots of neat and helpful things. This was actually a collaborative that was developed by an orthopedic resident in the UK and a surgical educator from Jeddah, Saudi Arabia. So again, it shows you how collectively the world can make a difference, and the difference can come from some unforeseen places. In addition to the ATLS app, one of the things that's on the horizon is applying gaming technology to ATLS, and it's likely that we'll have online games as part of the ATLS course for our younger learners going forward, which I suspect will be quite popular. The app, interestingly enough, has been downloaded tens of thousands of times already, and it's being downloaded in many, many countries that don't teach ATLS, so it's even broadening the impact of the course. So I hope that I've covered the background and organization. I hope that you understand how the course gets revised. We've reviewed some select revisions. We've talked about the educational format, and I've given you a bit of a taste of what is to come in the future. The ninth edition actually was just published, the changes in the last year, and again, there's a large compendium of supporting references. So if you need a good bibliography for ATLS course content, there are probably 160 publications attached to each of these two ATLS summaries that would be of use to you. So with that, I'd like to thank you for your time, and I look forward to more of this outstanding symposium. Thank you.